Well, let's begin, and we've got a little bit of housekeeping before we get stuck into the content. So, welcome to this webinar. This is a very exciting one. I'm actually looking forward to the next hour and a bit discussing the broad topics of containment and boundary setting, and how to look after yourselves, or how we should look after ourselves within the framework of working with alcohol and other drug patients. I want to start with very importantly acknowledging and recognising the traditional custodians of the land that we are all working from. We're all from diverse parts of this great nation, so I really want to acknowledge the traditions and the custodians of these lands. I'm personally working in Wurundjeri country, and I want to pay my respects to elders past, present, emerging from all our lands. And also, I suppose, going on from that, also acknowledging our own traditions and where we've come from, and the history and the values that we've come through from our generations. We've all got our own stories, and if we could just acknowledge and recognise that we're all bringing our own biases and lenses to our work. I suppose we're going to explore that a little bit further, how that may actually relate to what the work we're actually doing itself. I want to introduce the team. You've heard briefly from Lizette at the start. Lizette's our coordinator who's doing all the background work. If you've got any technical issues, she'll be helping to sort those out. And so she'll be in the background doing a fair bit of the work. I've got a couple of co-facilitators. I'm the one doing all the talking, but all the hard work through the chat room, we'll talk about that in a second, will be managed with Shani and Simon. So we've got some very able-bodied educators, experienced educators, to help us with some of the chat questions and feeding into the panel discussion. And I've got a couple of wonderful panelists, a very experienced Dr. Vin Tran and Chris Longman, both from different states, and I'll get them to introduce themselves because they probably can do that much better than I can, because they know a little bit more about themselves than I do. So Vin, do you want to start us off? Who are you, where you're from, and maybe a little bit about what's happened this week for you?
Okay, so thanks for that, Paul. So I'm Vin from Springfield, Queensland, and I think when I started medicine, one of the things that I've always interested in is, I guess, human relationships and the feelings associated with health, along with all the scientific stuff, of course, being a GP. But I certainly have a very keen interest in emotional literacy, because I really think that if we have better emotional literacy, then we can manage our emotions much better. The same way as if we have better numeracy, we can actually manage our maths problems, or solving maths problems in our lives. So really, I think I can sum that up. Is my particular interest is really dreamy goal of mine is to improve emotional literacy for I guess the community and the society at large. So hopefully, if I can introduce or encourage more GPs to be, I guess, obsessive about in this space, then that'll be wonderful. So I think that's my main agenda there, Paul.
Excellent. Right. And Chris, tell us a bit more about yourself.
Thank you, Paul, and good evening, colleagues. Yes, I've been a GP in Melbourne, in the western suburbs of Melbourne, for 37 years. I still love general practice, and I got involved in addiction medicine many years ago when it started to become a problem in the area. So I rolled up to the local drug service that had only been open a few months and said, "You better teach me something." And they did. And then 3 months later, they offered me a job. And I stayed there for 11 years. And it's something that I think can be really well done in general practice. And to be skilled in this area is something great you can really offer your patients.
Mm. Now, for those that haven't attended our webinars before, these are probably less traditional in format. We don't really have a presentation and then Q&A at the end. It's very much a discussion-based panel discussion. We may be throwing a couple of slides up just to help further discussion, but very much it's a round table, and you're invited as part of that table. So I'm going to get Lizette just to talk about some of the functionality we can utilise, or you can utilise, to help involve yourself within this webinar.
Hi everyone, thanks so much for those of you who are just attending right now. We haven't missed any content, we're just going through some housekeeping. Dr. Vin and Dr. Chris have just introduced themselves. So you'll see at the bottom of our screen today, we have the Q&A tab and we have the chat tab. We've enabled both of these functions for you tonight. If you want to ask an anonymous question to panel where you don't identify yourself, you can do so by using the Q&A tab, and then you can send an anonymous question. If you want to make a contribution, but it's not a question and you want to use the chat, if anyone has attended AOD Live, you'll notice that that's the way that we engage a lot with our panelists. So you can use either that feels right to you. Simon and Shani are behind the scenes and they'll answer your questions. But if you want to throw up a big question, please feel free to add it. Also, in the Q&A tab, you can vote. So if somebody asks a question and that really resonates with you, then you can upvote it and our panelists will know whether there's an issue that is really affecting more than one or two participants. Thanks, Paul. I think that's about all for the moment.
Well, great. Okay. Well, actually, when I looked at the topic of today, I was my curiosity, and I thought, well, what are we going to be likely to be covering? And really, a lot of it's going to be coming from the questions and discussion. Then we'll see where it goes. But there are some themes that we thought about that may well inform us in terms of where we're going to go with the content here. So let me just pull up here. So here it is. So possible concepts we're looking at how we can manage and trying to to some extent, hopefully prevent stress, not stress, but the burnout part of things. How can we manage that stress that we have in a part of our professional lives? Looking at building rapport and where things can go wrong in terms of either getting too enmeshed with a patient or too detached, and trying to find that sweet spot, how we can do that. The dichotomous issue of either too much self-sacrifice or self-preservation, and where we may fall into either trap, and how to recognize that and also address that itself. Vino, I'm sure we'll be talking about the inner and outer compass framework. It's a nice little way of considering where we sit and how we relate to the external or our internal world itself. With our patients around alcohol and other drugs, they exhibit often behaviours that are very much a survival instinct. And I'm going to explore, especially with Chris's experience, how she sees some of the behaviours and how she frames it to make it a bit easier to become therapeutic and less judgmental or creating a barrier unnecessarily. And really, a lot of this is how do you maintain hope for patients when things aren't going so well for them? It is challenging. I'm going to just stop screen share because it'd be nice if you're actually on a device, if you're up in usually the top right hand corner, there's the option to go gallery view, and that way you can see our whole panel at one time. You can see all our facial expressions at the same time. If you're watching via video later on, you'll only have the speaker view available. So we'll make sure that whoever's speaking will be obviously available to you, and you can see that there. I'm going to give you a couple of prompts here not to my panelists, but to you, the audience. And I wanted just to see if you, I suppose, relate to any of these statements. So I'm just going to go through a couple of statements and just see if any of these you think, yep, that's me, or I've done that in the past, and just see, because I think this is going to be an area where we can start the discussion. And so firstly, do any of these describe you? So firstly, do you have, I suppose broadly, do you have difficulty containing the drug-seeking patients, the patients that are really potentially pushing your buttons with manipulation or behaviours that you find quite challenging? Do you have trouble containing those? Do you find yourself taking phone calls unexpectedly from needy patients? Do you find you sometimes are sharing personal details with your patients in the attempt to try and develop rapport? Do you find, how often do you stay back late after clinics actually ended to finish off things and make sure things are right for patients and making sure that they're well looked after? Do you find once you've finished work, are you worrying about patients, and how often does that occur? What sort of level of patient complexity do you find that you do worry about your patients outside of your working hours? Do you relate to feeling almost like you're the only one who really understands some of these patients, and some extent feel like you're the only one who really can help because you're the only one who can understand? Do you relate to that thought? Do you notice feelings of friendship or attraction to a patient? And has that happened to you in your career? How do you feel about that? And how we respond to those sort of reactions themselves? What happens when a patient or family even referred to you as a friend or part of their family, and almost like a much more personal relationship rather than a professional relationship? How do you respond to that sort of intimacy in terms of friendship? Another thing I'd like you to reflect upon and think about whether you relate to is, especially this time of the year, do you receive gifts from patients, and what level of gift do you become uncomfortable with, and what level of gift do you feel is actually culturally appropriate from that point of view? Christmas time is a common time to receive gifts, but it can happen any time of the year. So again, just reflecting on how you relate to gift giving and gift receiving, and whether you feel like it's a boundary violation or whether it's accepted practice. Again, I'm just asking rhetorical questions, but again, an opportunity to self-reflect on this itself. The other thing, from the other end of the spectrum, from gift giving to a bit more frustration, do you feel frustrated that the system, the broad system's just working against you? You're trying to do the best thing you can for your patients, but it just won't allow you, whether it's Medicare or the bookings or policy or politics, whatever it may be. Is a system not really allowing you to be the doctor that you want to be? Is that a frustration that you experience? And the last one here, when you have something that you've struggled with from a clinical point of view, do you label them as failures? Do you find you dwell on them, or do you, and also, do you forget the successes? Is there a lens or a bias that allows you, or I suppose, focus on things that are a little bit more challenging, and that maybe colors the way you see your professional world? So again, lots of little prompts there. And I know myself, when I was reading those, I'm going, yep, nope, yep. Quite a few of them over my career I've certainly ticked. And I don't know if I've got all the answers to those things, but this is not necessarily about having the answers, but about sharing some experiences and then talking through as a panel some of these issues themselves. So Chris, I'm going to start with you. Having just gone through that little list of possible areas where we can run into trouble or find ourselves, you've been, I'm not going to talk about you as for yourself, but as a medical educator, you've had many decades or a few decades of experience of teaching, particularly registrars, but also other doctors as well. Have you noticed any of these in particular are more common with GPs? What have you noticed yourself?
Probably all of them at some stage, Paul. And I'd go to say that if you haven't struggled with all of them at some stage in your career, you're probably not a GP. Which brings me, I guess, to, I think one of the most powerful tools that I've learned from working in GP training is that of some sort of self-reflection. And, I intuitively do it at the end of every consultation, just what worked, what didn't, and some, when you're left feeling uneasy about a patient, and I often park that till the end of the day, maybe talk to a colleague, something like that. And I found that just a powerful tool, particularly in working with patients with substance issues, because they can be quite complicated at times. They can be manipulative. They can drive you nuts. Whole range of, so that's a bit of a roundabout answer to your question.
No, that's all right. Actually, I was just thinking when you were saying they're complex, I'm thinking there is this complexity of behavior. There's also complexity just with the pure clinical stuff outside of the interpersonal stuff. Alcohol and other drugs generally, I think about alcohol as a typical prototype. It affects so much social stuff, so much psychological stuff, so much physical stuff that the complexity of what you need to assess and then address as a GP within the limitations of our general practice, it gets quite complex. Let alone the comorbid mental health issues and how you negotiate the interactions with those things, as well as how you interact, the interactions with other services, how you actually engage resources. This is a tough gig. The education program we're running from the college is trying to help provide some skills and some frameworks to allow our GPs to address it much better. Or more effectively or more comfortably. But even within that, it's quite complex, let alone the behaviours that sometimes are more personally challenging. Vin, can you recall any patient in your career that's pushed your buttons?
I think all the time, and I certainly agree with Chris there, is that if you can't relate to any of those questions, you probably haven't been in general practice for a long time. So definitely, and interestingly, Paul, one of the things I always teach my registrars is that one of the great things about, I think, general practice is that whenever you are triggered by an event with your patient, it's usually a prompt for me to reflect and say that there's some sort of baggage that I have that I need to clean up. So that's something that I do over the years. Every time I react to something, I always ask myself, what's the belief and values that I have that made me react this way? And it just gives me a chance to sort of in a way, sort of update my operating system, so to speak.
Mm.
So it's not easy, of course, but that's certainly a way that I usually frame it. Every time I'm triggered by something, it usually means that something to do with my beliefs and values that made me react that way to that.
Yep.
So yeah.
Hopefully
I.
Well, we might get back into that shortly. I was just noticing in your chat, in the chat function, you put the term biopsychosocial. Is that the order you frame most of your work in, or how do you? Is it?
Yeah. Well, to be honest, Paul, if I have my way, I'll frame it the other way around: social, psycho, bio, because I think a lot of the times, as you know, in general practice, when people have poor physical health, it affects their mental health, and when their mental health is impacted, they go into fight or flight mode, and that will affect their relationships with the people around them, their children, their partner, people at work, and their relationship with themselves as well. We usually find that when people are under stress, they tend to be very self-critical, very self-punitive. And that, of course, creates more mental health issues, and then that leads to more physical health issues through, emotional eating, drugs, alcohol, gambling. You'll see the whole spectrum in general practice. And then that creates more mental health issues, more social issues, and you'll see this vicious cycle. And a lot of times, I think people, by the time they rock up to the GP, all these domains are impacted. Usually if it's just one domain, they'll put up with it. 2 domains, they'll probably consider seeing someone. 3, they definitely rock up.
Absolutely. I was just reflecting when you're saying that when I suppose looking at myself, when I'm tired or when I'm running late or when I'm those hungry or the whole type of things, when I'm when I'm not on my game, a patient comes in with emotions, I often take on those emotions and feel anxious or frustrated or angry or worried or hopeless along with them. That counter transference. Although when I'm actually on my game, when I'm actually feeling well and replenished and got the energy, it doesn't seem to absorb as much. I can sort of notice it, and I sort of use it therapeutically to reflect on the patient, how they're feeling, or at least to assess that. It's interesting how much our own personal state relates to how much we do or don't take on as some what the patient's bringing into the room.
Yeah. And as general rule, I find that, I often get people to rate this too, Paul, from a patient point of view. I get them rate out of 10. Their physical health out of 10, psychological health out of 10, and social out of 10. And often, if subjectively around about 7 out of 10, they tend to be okay. And I guess from a self-care point of view as well, I find that if I'm below 7 in any of these domains, I'm probably not going to be as effective. I'm going to be more prone to stress. So I think that's an important self-reflection as well. Whenever we stress, it's one of these domains that can be the issue.
Yep.
Yeah.
And Chris, what do you, when a patient comes in with, I suppose, some desperation, there's often an urgency about their presentations or they're saying things that really misalign with best practice. How do you respond to that in terms of, both in terms of your assessment of them, but also your own personal response?
I guess take a few deep breaths, think, whoops, have a quick glance at the clock, and then quickly decide what needs to be done now and what can wait, because I can't. In fact, I had one today, and someone I'd not met ever, who usually sees one of the other doctors, who clearly had a number of issues to present, including mental health and some DNA. And I guess really the first thing I think is to listen very carefully about what they're saying and really try and reach some sort of agreement on what is really concerning them. Mm-hmm. And often what's stated may not be really what the problem is. And, try and just sort of pull it together and then come up with some sort of very rough sort of plan that, yes, I'm very happy to help you, and how can we move ahead, and let's just write down a few things. So I guess that person leaves knowing 2 things: that you're really prepared to help in any way and to walk the journey. And I usually say that as they leave, I say that I'm more than happy to help you with any of this that I can. And so will my colleagues in this practice, and we all work together. And if you're more comfortable with one of the others, that's okay by me. What's important here is we get something done for you. Mm-hmm. And I see that we need to do this, this, and this. And, you know, I'm sure that we can find something. And then I quite often say to all patients, and if I can't sort this out for you or help you sort it out, I'll find someone else who can.
Yeah.
You know, so that's probably what I would do. And I think it's probably what most GPs do.
Yeah, I suppose the thing you mentioned there was making it overt, that you're there for the long haul, not just, you know, sometimes it's sort of implied, but patients may not appreciate that. And so being quite clear and open with that promise of being available.
Yeah, I think particularly, Paul, and Vin, working with patients with addiction problems, they'll often come in and, you know, you see this sort of a big deep breath and they're scared, and will they take a risk and tell you, and you don't know whether it's going to be something like that or hemorrhoids or a sexual difficulty or whatever. But I think if one of the real things I've learned is you must look totally comfortable and even convey that. And a few years ago, I did a diploma in drug and alcohol studies at Adelaide Uni, and it's hanging on the wall. And sometimes I say to them, look, I love working with people who have concerns about their substance use. I like it so much, I've even got a special certificate. And I point to the wall, and you should see the look on their face when they suddenly say, oh, because they're often used to GPs not actually wanting to see them. And they've often got great, can I say, bullshit detector? And they can quickly recognise doctors who really don't want to do this. And I think particularly with substance or very sensitive topics, you know, when you in some way tell them that you are important to me, your problem is important, I will help you to the best of my capacity, that sort of thing. There is a huge look of relief. I mean, you would have seen this many times, Paul.
Yeah, I have. Look, my job is to play a bit of a devil's advocate with this. So you're suggesting, I mean, I'm going to incorrectly paraphrase you, but and deliberately, you're suggesting that basically you promise that you'll be there to care for them, and you're there for the long haul, and you're there to be non-judgmental, and there to really make sure that their needs are met, even if it may be, you know, beyond their symptom itself. That's what I'm hearing from you. So what's to stop us basically getting so enmeshed with this that you know, we become almost colluding with the patient because they realize that, hang on, I've got a GP here who promised the world. And so where do you set the boundaries? How do you maintain a therapeutic relationship while still maintaining your own self-care with this? Because they can certainly, I mean, not just with these patients, but also patients can really take us along for a very emotional journey if we allow them.
Yeah, that's a...
I'll give you a bit. I just noticed Vin nodded his head, so I'll give you a moment to pause and think about that. And I'm going to put Vin on the spot with the same question. Well, how would you balance, or how do you see? Is there any way you sort of think about the balance? Actually, I've got a little slide looking at boundaries themselves. I might just throw that up if I can.
Yes, Paul.
So I'll just. That's all right. I'll just throw this slide up just to talk about boundaries and the range. So if we're looking at the boundaries, then we're actually, the sweet spot's at flexible boundaries that aren't too rigid, and we're not going so far that we disengage from the patients altogether or disengage the relationship, but also we're not going over the boundary where we're enmeshed, as I said, really enmeshed with the patient, and then it's hard to sort of become sort of objective and more professional, getting a bit too far. So that's a sort of a spectrum of where boundary setting can be. And there's boundary crossings where people will cross that boundary, but there's no real, I suppose, manipulation or abuse of either party around that. And there's boundary violations where basically people cross the boundary and there's a mismatch of power. There's dysfunction around that as well. So there's various types of boundary, movements, but I just want to put that up there as a little framework. But Chris, you were going to respond then. I interrupted you.
I think certainly I haven't had any issues with boundaries there. Doctor body language to some extent. Sometimes if a patient might, I'm trying to think of an example, but I might say, look, my role is your doctor, not necessarily your friend. I'm very happy to be friendly, but, you know, I have to take an objective view, and I will even challenge you about things you like and dislike. Sometimes I talk about my role, which I think is the role of really all health professionals, is that I will provide you with support, but I'll also provide you with challenge. And if I don't do both, we're not really helping you, because partly your problem has often arisen because you've slipped into a certain way of living, and I need to challenge that. Yeah, I think that's probably most how I do it. With patients, I'm starting on pharmacotherapy for our colleagues who are listening. I'm talking about methadone or buprenorphine. I have a conversation telling them what I require of them. You know, that is, I do expect you to arrive on time. I expect you to treat me with respect, and the staff. And then I also mention, by the way, we expect that of all patients. But then I add what they can expect of me, that I will attempt to see you on time. I will always attempt to keep your best interests at heart. I will not treat you as a patient in a clinic, so we don't bring our patients in with substance use problem and corral them in a corner and that sort of thing. You will be like anyone else in this practice, so that it's set up as a two-way professional relationship, not just I expect you to turn up on time and not be rude and, you know, not miss appointments and so on, and go to the pharmacy every day and that sort of thing. And I found that's worked really well, because they've often had bad experiences with medical professionals, often because those doctors are uncomfortable about what to do.
So I mean, you talk, you gave us some really good examples and some phrases you use to make it quite overt about where the expectations sit, and also where the care sits as well. It's not just about, you know, being rigid and rules. It's about you know, exactly your role as part of being, you know, a caring health professional.
The only other issue that crops up for me, and probably any rural colleagues that are listening, is I live very close to where I work. And about 50 yards down the street from me is a Safeway supermarket, and I regularly meet patients all the time in the supermarket. So I often say to them, look, by the way, I live in Williamstown. We may well run into each other down the street. I'm more than happy to have a chat, but not about work. When I leave here, I don't think about work. While I'm here, I only think about work. So by all means, come and have a chat, but we won't be talking about work.
Yes.
And that's worked brilliantly, because often when you do run into somebody outside, that they are immediately uncomfortable. They don't know whether to pretend they didn't see you or to come up and say hello. And for me, that's been very helpful. And I often, you know, sit in admiration of rural colleagues who live with this every day.
Was actually, you remind me of my first GP post, which was actually an alcohol and other drug specific post, and I was doing that rurally, and I had a patient who were working through alcohol issues, and he was working to basically trying to be, you know, his aim at that stage was to be abstinent. And then on the weekend, I was just walking through the street and walking past a bottle shop, and he came out of the bottle shop holding two slabs of beer, I think it was. He saw me and just receded back into the shop. He just walked straight back in as if it didn't exist. And I just smiled at him and just waved and moved on. I wasn't going to sort of, you know, engage. And also, you know, obviously the confidentiality around being, you know, whether he's a patient of mine, that was also pertinent with other people around. But it was interesting. And he came in the next week, and he was obviously quite aware of the situation, but he wouldn't speak of it. And I thought, well, you know, the option for me was, do I bring it up? And then we discuss that itself, or do I just let it be going? So I thought, look, you know, what happens on the weekends? You know, that's you know, I wasn't at work at the time. I was just I was shopping, and you were obviously shopping as well. There's obviously something there we can discuss. If you want to discuss it, you know, we can talk about that. But I'm not here to spy on you and stuff. So yeah, just trying to, you know, avoid that. I mean, I was very naive at the time. I'm not sure if I had a right approach or not, but I certainly felt there was an awkwardness about knowing the patient seeing. I suppose if I was walking out of the bottle shop with a slab under my arm and the patient saw me, I'd probably just be just as mortified. So yeah, it is tricky, especially when you are in close proximity to your patients in work and play.
Would you say it's important to preempt setting up boundaries then for patients? It sounds like you're trying to predict and preempt that boundary setting with patients before transgressions happen.
Yeah, absolutely. Chris has demonstrated some really nice phrases around as you're saying, preempting, preventative, trying to avoid getting to a muddle, so everyone's on the same page and everyone, has expectations that are understood by all, or at least they can be vented and agreed upon very early on. There's nothing worse than a therapeutic relationship with one party having an assumption and it doesn't match the reality of the other party. That's where there'll be a clash at some stage. Vin, I've heard you talking about a thing called a compass, and I'm just thinking maybe there are some types of us who are more likely to have difficulty with boundary setting around this compass framework. Can you tell us a bit more about that?
Okay, so I think, Paul, one of the most difficult thing about emotional literacy is that there's no real clear consensus. So we sort of have to be a bit more creative in this space. So I call this the inner compass versus outer compass. And really, I guess to understand this is that all of you out there, if you can reflect, some of us are very much what we call outer compass people, and that has to do with our personality. We tend to make decisions or do things based on the thinking and the feelings of others. So we tend to be more conformists. We tend to be very good with social norms. We tend to sort of do things that make other people happy, making our patients happy. And the problem, that's a good thing. There's a price to pay there, is that if you do this all your life and you're actually excessive with it, then you start losing yourself. You're starting to sort of realize who are you and what are your values and why do you have to go do these things against your principles. And then, so that's, think of the outer compass people is better at creating social harmony or outer harmony at the cost of inner disharmony. And then the group of people that are more inner compass space, who are very clear on who they are. They're very clear on their principles and very clear on their values, and they tend to make decisions based on that. The downside for them is stubbornness. And the problem there is, if their inner compass is so different to the outer world will look in and say, this person's so weird, and they're not even adaptable to the world. And so the key thing is to understand which one you are. I think the doctors that are more outer compass space, who work in this area of alcohol and drug addiction, etc., I think are more vulnerable to stress with this scenario, because if you go against making people, obviously setting more boundaries, and then people are very unhappy with you, then it's very hard for you. Whereas the inner compass folks tend to be not probably more adaptable in this scenario. Having said that, I think if the more outer compass you are, that's great. If you're aware of it, then you learn to be more inner compass. So acceptance commitment therapy is to train people to be more inner compass. If you think of it like that, Paul,
yeah.
For those who are aware. And then in order to teach the other way, it's actually a little bit harder. So you sort of, if someone's so inner compass and not conforming to outer rules and empathy and outer feelings, you have to teach them empathy, but that's actually much harder. Yeah.
Yes.
So hopefully I haven't confused everyone through that, Paul.
So to make it, trying to be a bit simplistic, but trying to just convey some understanding, the outer compass person is really the person who wants to keep other people happy.
They tend to make decisions based on let's say the feelings of us. I mean, certainly there's a lot of doctors there who tend to make decisions based on the feelings of it. So if someone comes in and say, hey, can you give me some Valium? And I really need this, I'm really stressed out. I really need this. The outer compass person will feel the urge to fulfill that more so than the inner compass person.
Yeah. And the inner compass person may be focusing on purely more, I suppose, objective clinical measures and not hearing the patient as much.
That's right. So then you may lose connection. So that's the balancing act that you have to do, that validation versus challenge. You have to connect with them. At the same time, you have to set boundaries. And that is the little bit of the sweet spot there, which is really difficult.
Yeah.
And is this about personality type as well, Vin, plays into this? Or
I really do think so, because you can certainly observe that. I work with a lot of kids on the spectrum, for example, and so I think you see the extreme. The extreme outer compass, I guess, can manifest as codependence, self-sacrifice, and then they burn out. And the extreme inner compass can be a bit on the spectrum. I guess. So it manifests in a different way, but as a general rule, the more extreme you are, the more, I guess, trouble you can get, the more adjustment issues that you can have.
Mm.
Yeah.
And Chris, I'm going to reflect back again, your experience as an educator. Have you seen doctors getting into more trouble with their patients because they're trying to appease the patient, or because they've almost ignored the patient's need and forgotten, almost non-patient centered altogether, focusing on guidelines and rules and missing out there's a person in front of them?
We're talking mainly about people with substance issues, Paul, are we?
Yeah, well, I suppose we are at the moment. That's our broad topic, but I suppose this comes across a whole. These themes will apply to all parts of our professional practice.
I think most of it would be that they're uncomfortable in dealing with what's in front of them, and so you sort of get into trouble because you don't have a framework in your own mind of how to proceed, or you start to become anxious about how I'm going to handle this. And I guess we're going back to where if a patient recognises that you're totally comfortable with this and confident, maybe you might not know the answer, but you know how to go about finding the answer, things will work so much better.
Yeah.
I'm not sure, have I answered your question?
No, it's all right. I'll push it a bit, not the same question, but just slightly push the theme a little bit further. When we're observing our patients, I think most of us have a reasonable compass in terms of assessing when they're distressed. And when they're looking exhausted, and we've got a bit of a radar and explore that clinically, whether it's a psychological framework or whether it's a physiological, looking at anemia or other factors. It depends on the patient and some percent what we're coming in with as well. I'm thinking about what we may see in our colleagues and whether they're the same sorts of things we would see in our patients, or whether our colleagues potentially, if we're looking at those that are, peri-burnout, what things can we look for? How can we detect that in others, professionally in others?
In our colleagues, probably I think the main one is they become cynical. And as you know, Paul, when I was working with the training program, mainly worked with GP supervisors in the last few years, and I saw a lot of that. And I think they really were burnt out. I think a lot of the supervisors were undervalued. They work like Trojans in supporting the registrars. They're trying to battle their own load. There's all the tasks they have to complete, forms and all that sort of thing. And I noticed just a lot of them became quite cynical. And I often think if I recognise that cynicism in myself, you need to step back. Well, sometimes you do at the end of the day, you think, I've just had enough, I don't want to do this anymore. And it's transient, but I think it brings us back to thinking at the end of the day, what's moving within me? Why am I uncomfortable? What happened today? What happened with this patient? Let's just step back and reflect on it at a deeper level. I just think that's such a powerful tool in recognising yourself in where your skills are and where your skills aren't, and when you need to move to someone else or get some help or whatever.
I noticed that Simon in the chat rooms put down an article. It uses the term compassion fatigue, and I think that's a sort of a clinical framing of feeling cynical and just losing the ability to really care.
Yeah, I remember, Paul, I don't know whether any colleagues here from South Australia, but Dr. Mike McDonough, who was a drug and alcohol physician when I first started working at Western Hospital, and he was an amazing man. He had a mind like nothing else, but he became very interested in chronic pain. Now, if there's one patient we all find difficult, it's chronic pain. And I remember saying to him, how do you do this? And he said to me, Chris, they become very, very anxious and very demanding. And so our immediate sort of instinct is to try and see them as infrequently as possible and sort of fob it off another week. He said the answer is to see them more often. And because if you say, right, let's come in next week and we'll catch up, they know they've got someone who supports them. The anxiety doesn't happen. They don't come in all wound up with this huge list of problems that they've gathered. You can flag what we're going to talk about. And I often use that sort of model when someone like that girl today who I thought, oh, here's trouble. This is going to take a lot out of me. I said to her, right, if you complete that and that, then you come in next week and this is what we'll look at completing then. That will take then, and then we'll move to that. And, what do you think about that? And so again, it was seeing her more often than less often and indicating your preparedness. And I find, once I've done something like that, I go home feeling a lot better. I also feel I've probably done something for them too, rather than just add to the list of doctors who doesn't want to see them.
Yeah.
Yeah.
If I just look at, it's thinking about, actually, I'm going to throw up a little slide again, which will help just look at this. So we hear about being a good GP, and a lot of us will relate to wanting to be obviously a very good GP for ourselves personally, but also for our patient community, to make the most of the training we've done and take some pride in our work. So that, and just in terms of what is a good GP, well, let me just bring that up. Whoops. Basically, all those things. If you're on the phone, you won't be able to read the things. But the things like being, being culturally sensitive and being evidence-based, helping patients with their employment or guiding them through that, making sure you're up to date all the time, dealing with relationships, dealing with the psychological framework, dealing with the physiological frameworks, being patient-centered, being on time throughout this whole thing, helping patients with their financial management potentially. There's a whole bunch of roles we've got as a generalist, a specialist GP, and often we're in a position where we don't have resources. We don't have the financial counselors, the psychologists, the drug and alcohol workers, the employment officers, all those things that would be wonderful if we had that wonderful wraparound care all the time. So we're often trying to manage this ourselves. And the question I've got is, how can I be all things to all patients? If I want to be a good GP, how do I actually be a good GP within the framework of how we're working? Vin, do you want to tackle this one?
I might. Yeah. So Paul, I was just put on the chat there, Paul, that I think I can sort of sum that up as biopsychosocial. And really, I think GP is a specialist of biopsychosocial, because we understand the interaction with all those three. And in actual fact, a lot of the times, I think folks who have issues with eating or drug and alcohol, at the core of it is, I think a lot of them actually have shame or disconnection or social issues down below. And that leads to a lot of anxiety and depression, anxiety and fear, and then leading to fight or flight responses and distraction, which then leads to all these other behaviors. Then that's the physical manifestations of it. And then it's a vicious cycle. And I think for us as GPs, the best approach for these folks is actually to manage at all those levels, really. We manage it at the physical level, but we need to manage at the psychological level, and we need to manage at the social level. So a lot of the times, I guess that's why I have a particular bias here, is that I think if we focus a lot on the social part, we will help with the psychological part, and therefore help with the physical part. But I think we tend to go the other way around. We tend to sort of try to fix everything at the physical level, just because that's how we train. And that's why I think we need to change these names to socials, psycho-bio, but it doesn't sound right, does it?
It doesn't roll off the tongue.
Yeah.
I know that there's been some research, not so much for GPs. We're missing a bit of research missing within the GP framework, but within drug and alcohol workers, about 1 in 5, so 20%, suffer from secondary traumatic stress. So basically, stress from the work they're doing with the patients themselves, as a form of vicarious trauma. Any estimates of how much GPs probably are experiencing a similar sort of secondary trauma through the work they're doing with the patients who are going through their own traumas?
I don't know, Paul. And I think it's probably not been heavily researched, if at all.
Yep.
I presume it's going to be a significant part. I think that the ones that are most vulnerable are the ones that tend to make decisions based on the feelings of others. I think that's the one that's highly empathetic, and I think they're the most vulnerable ones. Particularly in I take a lot of registrars, and I certainly see that group of registrars that I tend to sort of make sure I look after them a little bit more, I think, because they're more vulnerable. And if I can add, Paul, I think just coming back to that topic there, I want to introduce the idea around, I guess you can say, call it enmesh, but really we call it fusion. So fusion is the ability of our mind to buy into a story, like watching a movie, and we can buy into the story. We know it's not real, but we can buy into that movie and have real emotions with it. So that's what we call fusion. And it gives us great empathy. But the problem with that is that it can give us, I guess, emotional trauma as well, even though we're not experiencing that problem. So that's what we call fusion. And then the second level, I guess, of detachment out is what we call diffusion. And I think, Paul, you put on the slide there, you call this flexible from a point of view of boundary setting. But we call this diffusion, the ability to, at arm's length, we can watch a movie, enjoy it, have emotions, but we don't take it too seriously. So that's what we call diffusion. And then third is detachment. Detachment is where we don't have a feeling about it. We understand, we know it at a logical level, but we don't feel it. So that's called detachment. And it's wonderful if you're a judge or even a surgeon, where you can detach from your feelings. So ideally, in a patient engagement, you fuse with their story so that you can empathize. You can diffuse to then solve the problem, and then you go home and you detach. So that's the ideal situation. But as you can imagine, some of us are not very good at detaching. And I think those are the ones that are going to be vulnerable. And then the ones that are very good at detaching, it's very hard for them to empathize with the patient. So then they have to learn the opposite. So in a way, I think, I mean, I try to teach my registrars this, Paul, but it is very difficult. It's like a lot of people drive automatics, and I'm sort of trying to teach them the manual of shifting gears, and it's very hard for them. It's very hard for them to shift gears.
Yep. I was there's a couple of people in the chat are just talking about being part-time and some of the challenges and around that, because you are not there as much being part-time, and I've worked part-time pretty much for my whole career as well, and I just noticed that the balance changes a fair bit. There's some times where it's very easy for me to just say I'm only there for so many days a week, and the rest is someone else's problem. And there are other times where I'll be checking in and with colleagues or even with patients' files, and so trying to balance that out. I feel that personally, both extremes aren't that functional. Is trying to find the happy medium, and so having a colleague or two in the practice that understands what I do, and so I can at least be reassured that on my days off they can actually maintain any urgent issues from that point of view, but also being quite clear with patients that I'm not there every day. So if they are going to email me, if they do that, there's an auto reply saying I'm not here that day. If they go through reception, they're quite clear that Paul will be in tomorrow, but today he's not around. So unless they, something's critical, then it would escalate to a colleague, and they could always contact me. But it is tricky knowing how much you should need to be available, because it is an area that isn't shared by all our colleagues. And also, but you need to have your time off and other roles we've got to do when we're working part-time. We've often got a full-time load in other areas, but not just with our clinical things itself. I think there's been a couple of suggestions. I haven't looked at all the chat room, but certainly having a work buddy that you can sort of job share the responsibilities when you're not on, that can be an important strategy there.
Paul, can I just add, when you have a work buddy or a colleague, if you're more sort of outer compass based, it's probably good to have a buddy that's more inner compass, just giving you that perspective. And certainly I try to be, if I have a registrar who's more inner compass, I'll give them the outer compass perspective. But if they are more outer compass, I'd give them the inner compass perspective. So I think it's always good. Now, some people are not bilingual, so then you have to try and find, I guess, that opposite person for you, so they can give you that balance, I guess, because otherwise you'll find it hard to balance.
I like that idea that you've got a colleague that's a bit yin and yang for you. Yes, not necessarily good cop, bad cop, but that label's a bit too much about right or wrong. But just someone who can provide a different perspective. I've got a colleague who's very much almost the opposite type of personality and clinical style. And so whenever the patient sees them, I get some nice feedback about the things that I've missed, which is not always appreciated by but it also gives me a chance to actually reflect upon a different way of approaching the same issue. And I'm sure vice versa, there's probably things that I do that they go, oh, I never thought about thinking about it that way. So I think that's a great tip to know your colleagues and utilize them in a similar way.
Yeah. Paul, I've always worked about 2/3 time in general practice and a third time doing other stuff. And I do encourage our colleagues to do that if they can, because jobs outside of general practice really, I think, enrich your practice. You know, you bring skills in and fresh ideas and you mix in with colleagues. But I also say to patients, look, in fact, I have arranged my hours so I am in the practice every day, but I won't be here next week. We share notes here, we work together as a group. Any doctor will help you, but X, Y, and Z have particular skills in obstetrics, so you might prefer to see one of those. Something like flagging when you're not there helps.
Yeah.
Because sometimes they get upset, then they come back and suddenly you're not there and you didn't tell them, and they had this expectation and so on. I have a buddy, Queenie. She's on leave at the moment. I'm discovering how hard she works with some of the patients I've seen this week, but she does the same thing for me, and we check each other's results.
Yeah. Yeah. I was just thinking, sometimes we don't, with colleagues as well, but also with our patients, it seems like we're on a different planet sometimes. It just, how their understanding of their illness or their framing in socially or whatever it may be, just doesn't, either I don't understand it, or we've just got different understandings or different appreciations of them. And I've heard, again, Vin, you mentioned something about operating symptoms. We were talking earlier today, and you labelled me a Commodore 64. I thought, well, I'll bring up that conversation again. Can you talk a bit more about your metaphor around? I think it was a computer-based metaphor about how we aren't all on the same page all the time.
No, I mean, I think in counselling, it's a lot of things are a bit abstract. So we tend to use a lot of metaphors or analogies to explain these abstract ideas. And I think one of the common ones I use is think of your mind as like a computer, and you have values and beliefs, and the way of thinking is your operating system. So that's your Windows operating system. The challenge for us as human beings is our operating systems often sort of, if we're 40 years old, I'm 47 now, so if my operating system is about 40 years old, and I'll probably try to update it from time to time, but the problem there is that the world's changing so fast now. And when there's a mismatch between the world, how it operates, and our operating system, our values and beliefs, when there's a mismatch, then that creates tension, that creates stress. And so that's the challenge for us, is that when the world is so fast moving, I mean, I guess 500 years ago probably didn't change that quickly in a lifetime. So your operating system is fine right out through your lifetime. But here I feel like I have to update it every 6 months or every 12 months. So that's the challenge number one that most of our patients have, and what we have as well. And then the other problem as well is that we operate in the social world. So we have a network of computers that we interact with. And the problem there is that some of us are operating Windows, some of our patients are operating iOS, and they don't quite understand us, and we don't quite understand them. And we don't even have the awareness to actually understand or reconcile that. And so you'll find that being a good practice is very important. You know, there's some patients that don't even get me, and I don't get them. So then I know exactly who to send it to, someone who's opposite to me, and then usually vice versa. And so I think that's the key acceptance, is that the problem in general practice is that we deal with so many people with so many different operating systems. And there are people that will get us and we will get them, but there are people that we just don't get at all. And we have to be multilingual. And I think that's the wonderful thing that I find with general practice, is that because we interact with so many operating systems, I think over the years I've been able to be multilingual in a way. Think of it like that. But my main language is still my primary language. But it's a bit like if my primary language is Vietnamese or English, then I can try and speak French, but I'm not very good at it. But at least I can understand it. And I think that's the key thing, is about understanding that. And so a lot of times I think with our colleagues as well, our colleagues operate in a different operating system as well. And chances are, if we don't understand our colleagues, they're operating in a different operating system. It's not because they're stupid or silly or whatever. They're just operating in a different operating system. Yeah, hopefully I haven't confused everybody on that. Paul.
No. Well, I suppose the computer geeks will be loving it, and those that are more into gardening are not, probably tuned out for a little bit there. So I won't ask you for a gardening metaphor, but I'm sure everyone can probably do the same thing from their point of view. Now, I'm just aware that we've been talking for a while, and there's been a bit of input via the chat function. Feel free to also ask a question if you want to just ask a question, and Shani and Simon will interrupt us and ask that live. Shani and Simon, while I've got your attention, because I've mentioned your name, are there any themes or anything you'd like to bring up that's come from the chat? Because I've been able to look every.
Yes, Paul. Mahmoud had a question about how to go about managing family members within the consult, divulging personal details, or dobbing on the patient, I suppose, and telling all their secrets.
Yeah. Now I'll increase the level of difficulty. They phone you before the consult to tell you these secrets, and then say, "But you can't tell the patient that I told you." That's always a fun one. But how do we manage the obviously they're there for a reason, their agenda, and most of the time it's very much focused on they'd like their loved one to improve, but sometimes their methodology of getting information to us is not that helpful. How do we manage the tension between the index patient and also the support partners, who are obviously going to be important as part of this patient's treatment plan and recovery?
It's a difficult, Paul, assuming the person calling hasn't told the index case. I would just take the information down and thank them very much for calling. I mean, we had this in my family when my mother was driving and shouldn't have been driving, not stopping at stop signs, and we had to stop her. And I actually called her GP and just said, "Look, I just want to tell you this. I'm not telling you what to do. I just think you should know that what Mum tells you isn't quite the full truth." And he did exactly that. He just said, "Thanks for calling," and left it at that. And I don't promise anything or whatever. I do sometimes say, "Look, it is more difficult for me if I can't let on that, you've told me this, and if you can somehow bring it that you can come in together or whatever." But sometimes that's difficult because the actual patient doesn't want the other person coming in, and sometimes there's things about the other person. They might be drinking too, for example, so it can be quite complicated, but I don't think that's too hard to handle. I think we just exercise confidentiality and work with the information the best we can.
Do you think maybe that's sometimes helpful to get an idea of family dynamics and interpersonal dynamics?
Yeah, definitely. And I can just think of a number of times over the years where I can remember one where a next door neighbour called me and said, "Do you have any idea that X is blah, blah, blah?" I had absolutely no idea, and I had to do everything to hide my shock and surprise. And I said, "Well, thank you very much for passing on that information. I didn't commit to anything," and it really helped me get to the bottom of why this woman was behaving. So, I don't see it as a huge difficulty.
The tip I would have is I often frame, regardless of the age, I often as an adolescent health consultation. So I'm there to if provided the patient's brought in, happy to have their others, whoever they may be, are in the room. I'll often get them to talk about their concerns, and then announce that as part of my usual practice to speak to the patient, in private. So if they kindly step out of the room, please, and we'll bring them back when necessary. And that takes away a little bit of the trap that I used to do, was basically sort of ask, "Is it okay if you're?" And so if there's a bit of pressure to stay, then the patient say, "No, they can stay," and it can be a bit awkward from that point of view. There are a couple of patients that insist on their support person being with them, and that's fine. But I try and frame it as a routine part of practice to allow that dynamic to happen. And when the family has left the room, then I'll reflect back saying, "So-and-so seemed concerned and they were talking about this, but let's talk about, I'm here for you. How do you respond to that?" And really make sure the agenda comes right back on the patient and not just on the family member's story, but it's part of the story now that's opened up. It is tricky sometimes. It's just to try and work out, because patients often can feel undermined by their family members, or disclosing too much they weren't ready to disclose, and all of a sudden it's out in the open and feel. So part of that's normalizing that, you know, some shame or guilt around these things is quite normal, but it's okay because it's private and we can talk through it, and it's become therapeutic rather than judgmental. So just trying to change the dynamics of that interpersonal conversation.
There are also resources for family members that I might mention. Look, are you aware of Family Drug Help or Al-Anon, or the narcotics equivalent, which I can't remember the name of, something like that, and you might find a fair bit of help from engaging with them at some level.
Yep, we've got some, I think Simon and Shani probably vigorously trying to find, we've got some family-based resources for alcohol or drug issues.
Yeah.
I'm sure they'll put it in the chat room in a second.
You know, they often feel terribly, terribly alone and ashamed, and so they can't discuss it with anybody. And, you know, the husband's always drunk, or, you know, wife's whatever. So, and to actually have some sort of people they can talk to that are in the same circumstances is often more powerful. I don't know whether Addiction Australia, many of you saw that on SBS, and they had a peer group that met each week, and you know, a couple of the participants, they had 10 participants with substance use problems, said the peer group was the most helpful part, because they sort of felt like they were in like company, someone who understood them. Even the facilitators of the peer group were ex people with substance use problems.
Yeah, the for those, thanks for putting that link up there. It's on SBS On Demand now, because the 4-part series finished last week, but it really is very pertinent. It actually covers, overlaps this COVID time, so it's very, very, very up to date itself. I find COVID's given us some unexpected benefits, as well as all the challenges. One of the things is a lot of the peer, or pretty much universally across the globe, all these peer groups are now online. So geography isn't so much of an issue now. It's about trying to find the peer group that works best for you. And I had one patient who actually, for curiosity, decided to get up at some ridiculous hour in the morning and log into a New York AA meeting to see what it was like, to see what it was similar to the Melbourne one he'd been to, and actually liked the group better. And so he's decided at 5 a.m. every day, or whatever time it was, is the best. It's what he's going in for. So there are some benefits in terms of losing the geography and having more options. And I find a lot of patients who are exploring some of these peer networks, and there's Smart Recovery, there's Narcotics Anonymous, there's Alcoholics Anonymous. They're all a bit different, and each group in itself has got its own dynamic. So I wouldn't be dismissive of one. You know, if someone went to one group, it's a bit like trying one antihypertensive. If it doesn't work, let's give up on the whole lot. You would try a different one. And I'd suggest that often it is about just trying to find a balance. Because if you find your community, it can be very therapeutic, just having that shared experience, as you say, and as that documentary exhibited really clearly. I'm just curious about the idea of cultivating hope. How do we... What are the strategies that we're using to try and maintain hope when often patients are coming in feeling both helpless, but also without hope? That they don't feel that the media portrays, addiction as something that's fairly hopeless. A lot of blame and shame around those, the patients that are suffering from it. So they'll be taking on some of those emotions as well. How do we foster hope, especially when we know that substance use issues are chronically going to be relapsing as well as remitting? So there's this sort of yo-yoing effect, and people feel like they've had a success, and then they feel like they've failed again. What are the things you might say to a patient, or how you would frame this to allow that hope to continue, so that they can actually feel like there is some benefit in persisting?
Sometimes, Paul, I find myself saying things before I've thought about it. I've often just suddenly said to patients, I'm so pleased you've come in about your alcohol problem, because I love working with people in this area. There's so much we can do. And, often I hadn't really thought about saying that. It just comes out because that's really how I feel. And they do often respond with a sense of relief that maybe someone thinks they're not totally hopeless or lost or whatever, and is prepared to give it a go with them. I think it's just about the way we conduct ourselves. By hope would convey hope. That we show interest, that we spend time, that we're not shoving them in and out the door with a quick script. Or just good general practice is what I'd be doing. Recognising that there will be plenty of crises along the way and working through them the best you can. It's funny, I had a patient in yesterday who I've been seeing about 5 or 6 years who's on methadone, and truly she's driven me nuts in many ways, and I have put really firm boundaries around her, and I've actually thought at times I've been far too rough. And she came in yesterday and she said, "You pushed me, and that's how I've ended up." She's done really well, doing so well, because you pushed me and you insisted and you blah, blah. And here I am feeling really ashamed, and she's thanking me. But I realised that she saw it, that I'd actually, I guess, tried to invest some effort in helping her, which hadn't been her experience in the past.
Yeah.
So before I'm saying I'm blowing my own trumpet, there's heaps of experiences that I've totally stuffed up too. You know, so, but just occasionally you have a win that you don't quite expect.
Yeah.
And that was a really nice win, because, you know, I'm now still sort of, I did actually say to her, what specifically worked for you? You know, it was a moment of connection. It was good.
Yep.
You highlight a lot, Christine, the importance of relationship and rapport. I noticed that throughout your storytelling. It's really lovely. It's the art of medicine. It's enjoyable to hear.
Thank you.
I think one of the tips we've got, and we talk about this in the treatment skills workshop, is that the idea of assessing someone's readiness to change in terms of behavior change and what sort of behavior we're actually looking at. And then being kind to yourself in terms of, you know, my job for someone who's a pre-contemplative patient, who's not really, you know, not actually even contemplating the issue, is if I can, through a discussion, at least get them to think about it as an option. That's a win. It's not so much getting to make the change, because that's not my role. It's their role to decide whether they want to change or not. I can facilitate that and help them with some motivational discussion, but in the end, it's up to them. So I don't get as burnt out probably around this and feeling angst that the patients aren't changing because I'm giving them all the information or trying to get them to change too much. Even a contemplative patient is a huge success, because it's the difficulty of not, you know, from the pre-contemplation to contemplation is actually a big step. We don't often appreciate it. We were waiting for the wins, and the wins for us often the patient who comes in saying, right, let's go, I'm going to quit, and in that action phase. But actually that's the easy patient, because they're already there for you. The harder ones, that actually the bigger wins for us, are the ones that are actually starting to think about it, and we're opening the door for that decision making to occur. And it doesn't always occur, and it doesn't always have to occur, but at least we're framing it in a way that is kinder to us, that we're not going to feel so burnt out, feel like we're losing. We can lose hope if we're only looking for a particular aspect of behavior changes, the win, and the rest is irrelevant in itself.
So Paul, Lizette would like me to mention one of my favourite statements, which is, I think aligns with what you've just said, that I believe we're responsible to our patients, but not for them. And that really helps me go home at the end of the day. I can't change them. I can only do my best. And it's the same, you know, sometimes you might prescribe some Suboxone or whatever. Oh, if you don't give me that dose, that won't hold me. I'll go out and use drugs. And I just say, well, that's your choice. I can't stop you.
Yeah.
You know, I'm not responsible for that, but I'm responsible for making sure I prescribe appropriately for you. And I think that can be really helpful in dealing with complex people.
So just Vin, I'm just thinking about one of your things before we wrap up for the night. The concept of self-sacrifice versus self-preservation. You know, looking at this and how we potentially will be framed or frame ourselves within this picture. Can you just explore what those two concepts mean and how you see that?
Okay, so this is not an original idea. This is actually from schema therapy. For those who may be familiar with schema therapy, I guess you can say schema is like the operating system, our values and beliefs. So some of us have what we call self-sacrifice schemas. We tend to try to fulfill other people's needs before our own. And I guess that's a wonderful thing to have in society, because that helps to care for our society and care for the people around us. And I guess people with self-sacrifice tend to attract to professions like medicine. The problem with that is that it's like the gas pedal and the brakes in the car. You need two opposing things to balance. And And so the problem for the self-sacrifices is that you'll burn out because you're not taking care of yourself. So the challenge there is that often the self-sacrificers believe that they have to look after other people first. And what they have to learn is to make sure that they have the oxygen mask on themselves first before they can look after many other people. And so they tend to struggle between the two domains of self-sacrificing, and then they burn out and they say, what about me? And then when they fulfill their needs, they feel selfish. So then they go self-sacrifice. And we see this alternating self-sacrifice, and then you feel like, what about me? And then when they look after themselves, go on holiday, they feel bad, and then they go self-sacrifice again. And they sort of yo-yo between these two. And I see that so much in my colleagues and patients, and actually teaching them to, instead of stepping on the brakes too much or stepping on the gas pedal too much, goes cruise control at 60 k's an hour. That's what we sort of try to teach people, is trying to find that balance.
Yep.
Yeah.
I just noticed there's a bit of, again, chat with a few resources and some talking about peer networks and support around that. I'm going to just get the screen sharing happening again and just go through a couple of options you've got in terms of getting some extra help. Our program has got a virtual community of practice available. So there is it's called AOD Connect, and it's basically small group online meetings that are very much flattened hierarchy, all teach, all learn, often with a subject matter expert to help guide some of the clinical discussion. Very much a sharing experience from that point of view, focused on alcohol and other drugs. So if you're interested in that, there's the email on the page there, and you can access that via our program's landing page on the college website as well. Yeah, there's a couple of other things I wanted to go for. There are some professional networks that are otherwise set up. So there is an opioid in Victoria, but it's available pretty much anyone can log into it. A pharmacotherapy network. There's the Opioid Echo, which is on Wednesday mornings. There's a few things that are already set up formally. And also think about other aspects such as the things like just one-on-one mentoring, whether you do that as a formal supervision or just have a colleague that you can sort of bounce ideas off. Have some group sessions within your practice and bring in someone to help guide some of the discussions like we've had tonight, but more personal and more practical for your own clinic itself. And think about things like ballot groups, possibly. They're very useful to help diffuse from the being fused with your patient, to actually see it from an external point of view and getting others input around that. And it's the format that works quite well if that's available to you. And I know this year it's a lot more things have been available online. So if you're rural or remote and don't have local resources, you can certainly access some of those resources potentially as well. So there are some useful ways of approaching our self-care using our colleagues and developing those communities of support, because we really are social beings. So the more we can share that, more we're going to look after ourselves. For broader, I suppose, resources that are very important. If any of you are really feeling quite disenchanted, cynical, burnt out, all the things we talked about earlier, and recognizing that in yourself, then please seek some help. Take some time out and seek some help. Each of the state Doctors for Doctors assistance lines are available on the slide there, and we'll make them available after the webinar as well. And there's a number of, there's even a burnout questionnaire that you can possibly have a look at there. Someone wants to put that in the chat room, we can hyperlink to that. So ways of reassessing yourself. Sometimes we're good at picking up patient cues. We're okay with picking up colleague cues. Sometimes we just miss out on our own cues, and it's worth reflecting on ourselves. And I suppose that's one of the aims of tonight, is really to be able to give us moments of self-reflection and see where we're up to. And we've talked through some of the strategies. So I'm about to wrap up, but I want to just give Chris and Vin a chance just to give us any other pearls, anything else that's on your agenda to explore before we wrap up for the night, and I'll talk about what's happening early next year.
Vin, go first. I'm just finishing typing.
I was hoping that other people may have very specific questions. I would love to make it relevant for you rather than saying things that are not relevant. Is there any questions from the group?
And while we're waiting for just a question to come through, I will put up.
Yeah. Actually, one more thing, Paul, I've forgotten about, back to hope there again. I think one of the things that I probably want to raise awareness is that we often, due to empathy, I think emotions are actually quite contagious. I think that's an important concept that that we as GPs will probably understand that. If you go in a room and there's a lot of, I guess, anxiety or fear or anger, we can actually feel that. So I think in order for our patient to have hope, we need to have hope, because again, if we are feeling very pessimistic about someone, even though we're not saying it, they will pick up that vibe. I think a lot of our patients can. So I think that's probably a very important thing is to cultivate hope in ourselves, so that we can help our patients to have hope and change from that pre-contemplation to contemplation. That's the thing that you're talking about there, Paul.
Yeah, and it reminds me that transference goes both ways.
Yes.
Yeah.
So that's the contagious part.
Yeah. And Chris?
I guess I'd go back to my starting point, Paul. Be reflective about what you do, and if you go home again and something's niggling at you, you need to chat to a colleague or sleep on it or whatever. And you know, when someone does drive me mad, I go back to thinking about, why do I do general practice? Why do I feel it's so important? And you know, try and focus on what's good about it. And I've been practicing a long time, and not infrequently. I mean, I went out to visit a registrar a few years ago in a coffee shop miles away, and I was waiting to visit the registrar, and a woman I'd never seen in my life, or I thought I hadn't, came in and bailed me up and thanked me for helping her. I delivered her baby 10 years previous. You know, and I had no idea of the effect that had on her, that you are doing a lot of good. You just may not realise it. You know, just by the sort of people you are, even the fact that you're here tonight talking about these things. You know, you are doing heaps of good, but just if something's niggling at you, it needs to be looked at and addressed.
So my challenge to everyone, I suppose, on that topic is to have a system where you can check in on yourself, whether it's making sure you have a little bit of time out in a day just to check in, or have a reminder on your phone just to see where your emotional states are, or how busy or how overwhelmed you're feeling, and just have then some strategies to diffuse that before it gets to a point where you're actually cynical and burnt out and actually really struggling, and that it goes into our personal lives as well as our work lives. So just have some early triggers that you can identify, use colleagues, trusted colleagues, to give you honest feedback around that, and then have some systems that may require some time out, or just some changes of strategy around things itself. It's certainly an art form in finding that balance, and you know, sometimes we swing one way or the other, and hopefully we won't fall off the edge from that point of view. Please utilize the resources that we put up on the slide there. And I want to just wrap up with just talking about next year. We're going to continue this webinar series on a regular basis, and we'll just give you a preemptive have a look at the first few topics that we're going to be covering. We'll be covering more than this as we go through. But on this, sort of related to this, look, actually supporting patients who have experienced trauma and various trauma. We'll look at the cultural safety aspects of looking after Aboriginal and Torres Strait Islander patients. And then we'll also have a webinar particularly looking at the new depot buprenorphine, the long-acting injectables, and how that's changing and modifying our options around treating opioid dependence. There's 3 topics we'll be covering next year. It's very likely that webinars will remain on the Wednesday night, and they will still be recorded. So for those that you can't make it, they will be available, as this one will be on our website itself. So that basically the easiest way to find all our work is rscgp.org.au/AOD, and that'll give you the landing page, and you can explore from there itself. So thank you for everyone for your very useful comments throughout the chat room. I want to particularly thank Vin and Christine for a very lively and pricked my curiosity in terms of talking about boundaries and containment. And Shani and Simon, you've been hidden behind your cameras, but if you want to just quickly reveal who you are, wave to the cameras and say something so the video can pick it up. Shani, who are you?
Hello, thank you so much for that wonderful discussion. I really appreciate it and learned a lot myself, and I'm sure that all the participants would be able to take quite a few practical pearls away from that discussion. So thank you.
So Shani's based in WA, and so is Simon. Simon.
Yeah, great discussion. And it's a lot of stuff that you can take away to work with lots of different sort of challenging patients in AOD and outside of it, actually, to be honest. And hopefully you'll get all the resources afterwards as well. We give a summary that will come out later.
Very good. All right. Well, I'll wrap up the formal presentation here right now. Thanks everyone for tonight. Keep well, look after yourselves, and have a very safe and healthy end of the year into next year, and look forward to 2021 being vastly different from 2020. So good night all.